My name is Brad Monk. I'm a gynecologic oncologist from California. It's a privilege and an honor to discuss with you this randomized phase 3 trial, which takes a novel compound called trabectedin and adds it to an established drug in ovarian cancer called pegylated liposomal doxorubicin, which you may know as Doxil or Calyx, depending on what part of the world that you're from. This is a very interesting compound in that it comes from the Caribbean sea squirt, an invertebrate that is delicate and has a toxin that protects it from its hostile environment. This compound has now been totally synthesized and is synthetic so that we're environmentally friendly, and now can be given to patients with soft tissue sarcoma, where it is approved within Europe, within the EMEA, and now we're interested in studying it in ovarian cancer. It binds to DNA. It's a cytotoxic. It binds to the minor groove. Most DNA-active drugs bind to the major groove. It forms macromolecular adducts, leading to downstream transcriptional dysregulation, a G2M block, and ultimately apoptosis. So we did 3 phase 2 trials as well as a phase 1 trial. The phase 2 trials established the single-agent efficacy in recurrent ovarian cancer. The phase 1 trial showed that it can be easily combined with pegylated liposomal doxorubicin. Based on those 3 phase 2s in the phase 1, we launched this 124 hospital, 21 country global trial to investigate if adding this drug to the standard pegylated liposomal doxorubicin compound could improve outcome. And not only were these patients with ovarian cancer, but patients with fallopian tube cancer and primary peritoneal cancer, which I think we appreciate have similar treatment and etiologic causes. All of these patients had measurable disease. They had to have progressed after frontline therapy, performance status 0, 1, 2, and could have only had 1 prior chemotherapy regimen. And this is the primary endpoint. The primary endpoint was improving progression-free survival. We thought that it was important to detect a 6-week improvement in progression-free survival, and indeed, at the median, the addition of trabectedin to pegylated liposomal doxorubicin improves progression-free survival at the median of 5.8 months to 7.3 months, again 6 weeks. This is a hazard ratio reduction of 21%. As you see, it's 0.79, statistically significant with a p-value of 0.019. Again, that was the primary endpoint. What we do, though, is when we treat patients with recurrent ovarian cancer, as Dr. Friedlander mentioned, if the patient recurs within the first 6 months, we call that platinum resistant. If it recurs after 6 months, it's called platinum sensitive. This is a subgroup analysis of platinum resistant patients showing no difference in time to progression, but the difference is even greater in the platinum sensitive patients, as you would expect. And again, the hazard ratio here is 0.73. Before it was 0.79. The p-value is 0.017. Before it was 0.019. Before, the difference in progression-free survival was 1.5 months. Here it's an improvement at the median of 1.7. The survival data are not yet mature. The study was powered for survival, establishing a difference of 63 to 83 weeks, improvement of a third, and this is not yet mature and cannot be interpreted. This is the response rate, and again, the response rate as well as the progression-free survival was based on independent radiologic review. It wasn't what the doctor said. They were sent to radiologists who were redacted to the clinical data and made an assessment if this was slowing progression or shrinking tumors. And as you can see, the difference in response rate by independent radiologic review or investigator is not significant in resistant patients, but highly statistically significant in platinum-sensitive patients. And again, the difference is approximately 15% by the investigator and about 13% by the independent reviewer. This drug causes bone marrow suppression. The reduction in skin toxicity seen in the combination is because there's a lower pegylated liposomal doxorubicin dose in the combination versus in the single agent. Cardiac disorders were uncommon. There was also a slight increase in fatigue, vomiting, and nausea, but there was an important difference in febrile neutropenia, very little neuropathy or alopecia. What I'm trying to say is this is a very user-friendly drug. Does, however, cause neutropenia, 72% grade 3-4 neutropenia. I said the febrile neutropenia rate, though, was 8%. It also increases the platelet transfusion rate seen at the bottom of this slide from 2 to 10%. I want to finish here by sharing with you the liver function test abnormalities. These happen in the middle of the cycle, and they're transient, and they resolve before the patient needs to get treated again, and generally do not require dose reductions. So this 46% grade 3 and this 5% grade 4 really doesn't translate into clinically important dose reductions. So the primary endpoint was met, prolonging progression-free survival when trabectedin is added to pegylated liposomal doxorubicin, a 21% hazard reduction. This is the overall response rate, 28 versus 19%, and the survival data are immature. Hand-foot syndrome was less because the dose of liposomal doxorubicin is lower on the combination arm. Cardiac disorders were uncommon, and although there was a 72% grade 3, 4 A and C toxicity, neutropenic fever was only 8%. And although we see liver enzyme elevations, they're generally of short duration, returning to normal prior to next cycle. They actually become better over time and occasionally require dose reductions and delays, although infrequently. Thank you.